And welcome everyone. I'm Bruen, and we meet at a promising but also quite a perilous moment in the pandemic. Gathered virtually alongside me here are some of the world's preeminent experts on infectious diseases and testing. With Visby Medical, we are organizing today's talk to take a look at the role that testing has, and more importantly, will play in the coming months. I am honored to have first, to my right, Dr. Piot, director of the London School of Hygiene and Tropical Medicine. He is an expert in infectious diseases, and in 1976 co-discovered the Ebola virus in then Zaire and led research on HIV/AIDS. He was founding executive director of UN AIDS and Undersecretary General of the UN from 1995 until 2008. He is currently a special advisor to the President of the European Commission on COVID-19. To my virtual left is Mara Aspinall, professor of practice and biomedical diagnostics at Arizona State University. She co-founded the Biomedical Diagnostics program at ASU, which is the first entirely dedicated to diagnostics as an independent discipline. She is managing partner at Bluestone Ventures and CEO of the Health Catalyst Group. She has spearheaded initiatives to educate payers and policymakers on genomics and personalized medicine. She served as an active member of the Health and Human Services Secretary's Advisory Council on Genetics, Health, and Society in both Bush and Obama administration, and is currently an advisor to the Rockefeller Foundation on COVID testing. And last but certainly not least is Stanford Professor Emeritus of Infectious Diseases and Chief Medical Officer at Visby Medical, Dr. Gary Schoolnik. He is also an attending physician in internal medicine and infectious diseases at Stanford University Hospital, and Associate Director of Stanford's Institute for Immunology, Transplantation, and Infection. While on the Stanford Medical School faculty, he served as Chief of the Division of Infectious Diseases and Geographic Medicine, and national service includes on the Advisory Council of the National Institutes of Allergy and Infectious Diseases of the NIH, and his role as chair of the NIH Trans-Institute Committee on Human Microbiome. I think I got that. Let me first turn to Dr. Piot. We have more vaccines rolling out every day. By last count, almost 600 million have been administered. Yet in most countries, Brazil perhaps as one example we can cite, there are still relatively high levels of COVID, with numbers even beginning to tick up. What can we expect to see from what appears to be, if I could ask a loaded question, a fourth wave?
Thanks, Brett, and hello, everybody. First of all, it takes a while before you see the impact of vaccination on, incidence on new cases of infections and on hospitalization and so on throughout the world. And secondly, the distribution of where vaccines are applied is very, very uneven. It's Israel and the United Arab Emirates that have the highest rates of vaccination, but even there we are only talking about 60% of the population, which is a lot. Here in the UK, I'm talking to you from London, about 50% of all adults have received one injection. In other parts of the world, it's like rather 10% or less. So there is enormous uneven type of deployment of vaccines. But soon we'll start seeing the impact. And for example, in those countries where they started vaccinating people in care homes or the elderly, we've seen already a major decline in deaths from COVID in those age groups as a result of vaccine. Because vaccination, let's not forget, what is the first impact and probably the first goal is to reduce severe disease, hospitalization, and deaths from COVID. And wouldn't that be wonderful if we can achieve that on a worldwide scale? But there is enormous inequity, in terms of vaccine supply. There are not enough vaccines in the world for the number of people. That's hopefully a temporary issue. And then there is also people who don't want a vaccination at all. So that's another issue. But yesterday was a great day for me because I've been working quite a lot of my life for equitable access to, for example, HIV drugs, but also to vaccines. And yesterday, the African Union signed a deal with Johnson & Johnson for 400 million vaccines. That's for a population of about 1.2 billion, but half of them are children. So that, in addition to the vaccines provided by COVAX, this is a facility that was set up by the Coalition for Epidemic Preparedness Innovation, Gavi, and WHO and the European Union. That will then make sure that in the long run, by the end of the year, we will have vaccines. However, a big unknown is the appearance of so-called variants. Viruses mutate. There's nobody, it's what we expect. But some of these mutations may be to the degree that they could develop viruses that are not going to be inactivated or were not protected from with our current vaccines. And so we'll have to see that some of these waves in Europe, we're going through a third wave because of the so-called British variant, B1117 for the amateurs. In Brazil, there's a variant that seems to be able to reinfect people who already were infected with an earlier variant. And in South Africa, we have another variant against which some vaccines are not effective, others well, like the J&J one, yes. Others, the AstraZeneca didn't, show any activity. So that means that even if vaccination is our best bet to go forward to some kind of normal, we will need to continue to apply other measures, non-pharmaceutical interventions, and also testing, one, to know what's going on, what's circulating, but also it will have to be a combined effort and just not one single approach.
Combined effort. And part of that combined effort, Mara, if I could turn to you now, is testing. Topic, obviously, we're going to focus on during the hour that we have together. But at last I checked, testing is actually falling quite precipitously in the US, down some 33% since January. Is this due to a lack of testing options, sites, or just that people are no longer believing that they need to get tested?
Well, Brett, I think there are actually three reasons why testing is dropping. And as you said, 33% nationwide, but some states are seeing close to a 50% drop off in testing. And I would say there's good news and bad news. What's the good news on the drop of testing? It's that as more people get vaccinated, there are fewer symptomatic cases, period. So fewer people are getting sick and therefore don't need to test, particularly in, as I said, the symptomatic. But unfortunately, there's also bad news. And the bad news is really three different areas here. Number one, and this is tricky to say, but it's a perception that, well, if I've been vaccinated, I can't get COVID at all. Now, the terrific news, CDC reiterated the data very closely that Israel has seen and that the UCLA health worker study have seen, that the mRNA vaccines, the ones who have been out longest, have a 90% protection against probably COVID broadly, but certainly close to 100% against severe disease, hospitalization, and death. So that's great. But it does not mean somebody who's vaccinated cannot get it and transfer it to somebody who isn't vaccinated. So that's number one. Number two is just plain testing fatigue. People have had enough. And I'm sure we all get that as we pass the 1-year anniversary and we don't have a specific end in sight. This is going to end on such and such of a date. And thirdly, it's what Peter just talked about, which is the variants. While the vaccines that I just discussed have broad protection, the protection against specific variants, particularly P1 in Brazil, I think it's 384 in South Africa, they have closer to a 47 to 51% effectiveness. So that's why testing needs to happen, but people are not fully acknowledging it. what I hope, and maybe we'll talk about this later, is the broad screening programs could be an answer to this with better testing technology.
I definitely want to get into screening, but let me now shift to Dr. Schoolnik. With these rising infection numbers, there is also something we're not seeing, a sad truth that the actual level of infections is probably, correct me if I'm wrong here, much higher, and that is because people are not getting tested. And so we don't really have a full picture of the challenge we're confronting at the moment.
Yes, that's right. It's estimated we have about 60,000 documented cases each day in the United States. And as Mara pointed out, that's a fairly high level is in the setting of a declining testing rate. Therefore, it's almost certain that the actual daily number of new cases of COVID is far higher than 60,000, which are the documented cases at the moment. Without population-based screening for public health surveillance purposes, it's really like flying blind. We really don't know what the daily rates are, and they could be increasing dramatically. And I think it's this that resulted in the CDC director's statement yesterday that we are facing a potential doomsday scenario with a fourth surge. Flying blind without testing is a dangerous situation. It's analogous to flying an airplane through a cloud directly into a mountain. For public health surveillance purposes, we must start testing far more broadly than we are doing it at the moment.
Thank you. And back to you, Dr. Piot. You said in a recent Journal of the American Medical Association article that new variants will continue to appear and that winter surges may in fact become the norm. So do you anticipate that you and I are going to be sitting here a year or 2 years from now still talking about, still dealing with COVID-19?
Thanks, Brett. By the way, my name is pronounced Piot, but anyway. The question, we are in this crisis, and the question is, what's the long-term trajectory? And of course, I mean, I don't have my crystal ball here, and it's impossible to tell, but it's very likely that what we hear of going back to normal, I think we can forget about that. First of all, it's going forward to the new normal, that we should think of it. And then we need to, it will depend on many factors. First of all, as Mara said, how effective will these vaccines be? And they're not 100%, but they're highly effective, particularly for death and severe disease. So that's good. But in terms of limiting transmission, that's still an open question. But also, how long will the protective immunity last? One from natural infection, but also from vaccine-induced immunity, which may be longer than natural infection, we don't know. But then the big issue is variants. Will we have waves and waves of new variants? And it looks like in the US, for example, this so-called British variant is now really moving all over, and then others may follow. The question is, we don't know what the diversity is of the variants. Maybe there are only 4 or 5 that are really relevant. And then we'll have to make sure that we develop vaccines that are active against them. But there is also a seasonal impact. I mean, as we've seen, when it's getting colder, traditionally we have more respiratory transmission. People that spend more time in closed rooms and environments. And the protection against viruses, I mean, our immune system is less effective. So what I think the future is most likely is that we will see hopefully a collapse in mortality and severe disease, and we go to what we would call low endemic, but then now and then an outbreak, seasonally with the winter, like we have with the influenza, either due to the fact that not everybody is vaccinated, Let's not forget that there are no vaccines for children, for example, at the moment. And even if children are less affected clinically, they could be, when all the adults are, or most are vaccinated, they will become a reservoir for infection. So, but that I think is a matter of time. We'll have a vaccine again for children also. But that we will need, to continue to be very vigilant. We'll have these outbreaks, and not hopefully like we have now, unless there are variants coming up that are completely, where the vaccines are completely inactivated. I don't think we'll go that way. It will be more not an all or nothing, but it will be more like partially, effective. But so it's not that we should count on the fact that it's going to be all right. And I think in Europe, we've seen it. In the UK, we had our third wave in January, just after New Year, around Christmas and so on. And that was brought under control with draconian measures, lockdown and so on, not by the vaccine. That started then. And now in Europe, on the continent, we see this British variant, really spreading like wildfire through the continent. And that, unfortunately, at the time when the measures were being relaxed from social distancing and face mask wearing, and at the same time that vaccine rollout is still not good enough. So again, we'll have to go for societies kind of living with COVID, rather than to hope to wipe it out. Let's not forget there's only one human virus that has been eradicated, and that's smallpox. And that took a long time with a highly effective vaccine that will give you kind of lifelong immunity and, massive effort. Maybe one day we'll get there with the coronaviruses, but we shouldn't count on that for the time being. So massive effort, vaccination, testing, and, continuing certain things like mask wearing.
Really important points about the unknown when it comes to vaccines, the massive effort that's involved. Mara, I saw you looking to get in, and in addition to what I'm sure you're going to build off of what Dr. Piot said, from a testing standpoint, what can be done as we're now seeing more and more schools, businesses start to reopen that's not being implemented at the moment?
Sure. So, and you're right. I want to follow up on what Peter said. Is number one, and Gary mentioned this: asymptomatic screening programs. We need to have a systematic approach that, unfortunately, it will become our second nature to regularly screen people. The challenge, and the others are more expert at this than I am, but we've rarely had a disease, if ever, that 2/3 of the people are asymptomatic, but still have full ability to transmit it to others. So what I have said with a little bit, I don't want to say humor in the midst of the challenge, but the most dangerous statement in the COVID era is, "Don't worry, I feel fine." It doesn't matter if you feel fine. You could still have a disease and transmit it to others who may not get such a mild case. And I think it's also important to recognize, and we probably will never have the data on this because of the vaccines, in a good way, I suppose, is my 92-year-old mother had completely asymptomatic coronavirus. Now there's a perception it's only young people, but full antibodies, test 1, test 2, test 3, because nobody believed it. So that's why we need to aggressively have screening programs. Just in the last week with the Rockefeller Foundation, we announced a suggested process for school screening as part of the $10 billion allocation from CDC. We need to do that, I believe, in private businesses to go forward and bring everybody back. And then one other quick thing that I would add is the testing going forward, hopefully 3 months from now, 6 months from now, may not be all individual screening. It may go to community and outbreak control. So more wastewater, in homes and apartment buildings, breath tests that are not very sensitive, but are probably good enough to get us into a sporting event. So the testing modalities and technologies are not the same as we had at the beginning of the pandemic, and should not be at the end when it becomes more of an endemic.
Well, and I do want to encourage those on the call, if you've got questions, please put them into the chat, and we will start posing those. But I've got one going over to you, Gary. When it comes to the test we currently have, are they picking up these variants? And do we have to worry about some of them missing these mutated strains?
Sure. Let me answer that question and then return briefly to screening again. The variants that Peter mentioned certainly have been of great concern for coverage with the current vaccines, and Peter Piot discussed very thoroughly the current performance of the vaccines for these variants. But the mutations that occur in these variants could also reduce the effectiveness of molecular tests. And therefore, it is imperative when using molecular tests to monitor the sequences of these new variants that occur, and to compare those sequences against the reagents that are used in these molecular tests to be sure that these current molecular tests still are able to detect the variants as they arise and circulate in the community. Now, currently, most of the tests that have now been authorized by the FDA are capable of identifying patients infected with any of the variants that are significantly numerous to be concerned. But going forward into the future, it will be mandatory to sequence as many viruses as we can in real time and through all relevant geographies. And then compare periodically, as often as every 2 weeks to every month, the new sequences as they occur, and look at how those new sequences would be detected by the current test. And it is entirely possible as we march into the future that we will need to modify currently authorized tests so that they are able to detect the new variants as they arise. I would even go further by saying it's not only the responsibility of the FDA to monitor the sequences, it's the responsibility of the federal government to be sure we have the sequencing capability to do this on a mass scale. Great Britain is the best example of a government that has funded very high levels of sequencing. Unfortunately, in the United States, currently, we are not sequencing enough strains as they arise, and we need to do better. It is also mandatory that manufacturers of diagnostic tests with operationalized the bioinformatics requirements to compare their reagents against these new sequences. And therefore, it's important that all diagnostic manufacturers have a bioinformatics capability and carry out this process on a regular basis. Now, Brett, if you will allow me, I would like to return to screening for a moment and just sort of expand on some of Mara's comments. So let's consider screening in several different contexts. First, there's screening of vulnerable populations. And here I'm referring to, for example, people receiving intensive cancer treatment in outpatient facilities. These are vulnerable people who have less resistance to infection by the virus, and if infected by the virus, will have a higher likelihood of severe disease, hospitalization, and death. We would include in that group the need to screen patients in satellite dialysis facilities, individuals who have received transplanted organs and are immunosuppressed to prevent the rejection of those organs, and those who are elderly and frail and who are living in congregant settings such as nursing homes. Screening needs to be done on a regular basis using highly sensitive tests to protect these vulnerable individuals. Now, on the other hand, Mara mentioned screening of children returning to school, and to that we could add screening of employees returning to the workplace. Here, screening is done on a periodic basis. Could be daily, it could be 3 times a week, it could be once a week, but it's periodic screening of the same individuals going to the same location. And then the third application of screening is screening for people going to one-time events. A one-time event might be a critical meeting, for example, reporters attending a press conference in the White House. It might be for individuals going onto a plane, or it might be the screening of individuals seeking entry into a sports arena. So screening has all of these different dimensions, and we need to fit testing of the appropriate kind for each of these different kinds of screening.
Thanks. And Mara, I know you had something to add on the variant surveillance.
Yeah, and I'll just emphasize, I completely agree with Gary that the setting and the process needs to be effective for that the test technology needs to be appropriate to the setting, and it likely may change over time depending on the background prevalence. The only other thing that I'd add to also what Gary said about variant detection and the importance of genomic information on the tests. Right now, I don't know if we'll call it lucky or not, but all of the antigen tests fully detect variants because the antigen tests are focused on the N protein, and all the variants of interest and concern are on the spike protein. But we'll have to keep track of that going forward as to whether there's a potential for that to shift in terms of other mutations in the future. But I also want to emphasize that on a genomic surveillance basis, we may, it would be great if we could do 5% or more of all samples, but I think we need to focus on the sickest of people. Some of the people that Gary mentioned in a different context, much easier. Why don't we genomic sequence everyone in a hospital? We know by definition they have more serious disease since they're hospitalized. So while we're setting up a random process across the country, I'd like to focus it on the sickest people and those who have been vaccinated. And if they turn out positive, we really need to know whether they have a new variant or the original Wuhan variant.
Yes, please go ahead.
Yeah, but if I may add on 3 points on the last one that Mara said. In Europe, the recommendation now is to screen, depends on the country, 5 to 10% of all isolated. But more and more countries are doing what Mara says. Outbreaks, environments like care homes, immunosuppressed patients, because they are the, let's say, ideal incubator or fertile ground for, developing mutations and variants. And that's how a number of variants have already been detected. So it's a combination of the random fishing expedition, to say so, but what I think is going to be more rewarding is the more, targeted type of sequencing. That's one thing. And a country like Denmark now is testing over half of all their isolates. So there it's nearly all or nothing, but it's 5-6 million people. Secondly, in the UK, when the schools reopened, parents and the pupils, because primary schools were given free tests for screening. I mean, they're like antigen tests, so that's now part of the system because, I would say there is not yet testing fatigue. It's actually, and also the teachers, by the way. And so it gives actually more, people trust more the environment. And we know it's not absolute, but it really is making a difference. And I think here, paradoxically, it may be that with vaccination, that the proportion of asymptomatic infections is going to go up. And therefore, in order to detect people who are infected and infectious, testing will become even more important than when you have a very widespread community transmission with so many people infected. Now, testing is going to become relatively more important as the incidence is going down and as vaccination is rolled out. And then finally, something that hasn't come up, but in Europe is in the pipeline, is what they call a digital green certificate. I mean, it's kind of a word for vaccine passport, but that's not what it is. But it's a digital certificate that not only indicates whether you've been vaccinated and with which vaccine and all that information, but also where the space for test results. And and that's going to be, I think, key for moving. You mentioned one event like taking a plane, but you know, with the summer coming up, people are eager to be able to travel. So again, that's a very different reason for being tested. But I think that even for people who are maybe not keen on being tested or being vaccinated, these practical considerations will then override whatever concerns they may have.
And I'm going to the reporters' questions next, but Dr. Piot, I'm coming back to you with one more personal question. When you're next looking at attending a conference, what are you going to want to see in place at that conference, health safety measures, to make you confident that it will be a safe event?
Yeah, well, I've never been a real big fan of conferences, but except for seeing my friends and colleagues and have the informal discussions. However, this going there, that's the first step. It's taking the plane, because that's one thing. So I'd like to see that everybody's vaccinated and that we do have a protocol for testing. And let's also not forget that the testing technology becoming more and more sophisticated, more sensitive, more specific, faster, more accessible. And so that's where you could argue for the big events that you could ask everybody to come through a scanner that tests you in no time. That's enough. Or you could ask before the beginning of the conference, everybody's tested and that's then valid for X days. I think that's we need to think through what is the most cost-effective and cost-beneficial algorithm for testing. I think that, to be honest, I wouldn't be surprised that even within a year, this will become like part of the normal, quote unquote. This is, and that's the way it is, and that just as I think anybody who has a cold or dripping nose or so should wear a face mask, just as they do in Japan, to protect the community. There's no big deal. It's not a political issue. It's just to be the best of being egoistic and altruistic. You protect yourself, you protect the others.
Part of the new normal. We'll need to get used to that and set expectations appropriately. Mar, perhaps this question is for you. Lorna Collier, reporter, is asking, are all US states now testing for variants? And if not, what are the barriers to this type of testing and sequencing? Is it financial, logistical, lack of understanding, motivation on the part of state governments? And how can these be overcome?
Sure. Well, the answer on what are the barriers, it's all of the above. There are some logistical considerations that need to happen to ensure that the sample is gotten to a lab that does genomic sequencing. Secondly, there is a logistics issue in terms of consent and having the patient involved consent, because it's an additional test. Some consent forms as part of a process or broadly in a state will include that, some will not. It's a payment issue. However, the federal government has allocated some funds to do this. How they're allocated by states and how states use them is both a complicated issue, and each state has a slightly different system. And then it's just a willingness as to whether states and Department of Health want to go through this extra step for people who have been working incredibly hard and have a lot of complexity. So it's all of the above. How can we fix it? Again, I'll go back to the Rockefeller Foundation has had a number of initiatives led by Rick Bright in this area, and a real focus on how to make genomic testing easier in the US. I do have to mention, however, and both Peter and Gary talked about this, it does need to be a worldwide effort, because if this pandemic taught us anything, is the world is not as small as some people would like it to be. We can't just look at the US and say, we've got it done. It needs to be genomic surveillance and information that comes from outside of the US as well as inside. So a little bit broader answer to the question, but it's critical in terms of looking at what happens next. Where do we go from here? Are the variants going to take over, and readiness for the next pandemic? So long answer to bring it around. There are a lot of challenges, but I'm optimistic that a number of states will do it. But again, I would go back to the sickest people now, given they are already in a hospital environment and sign a lot of consents. Let's start with those in all 50 states.
Just to start.
I may ask, add
yes,
something.
please, go ahead.
Yeah, in the UK, there is a sequencing program supported entirely by the government. And it didn't come out of the blue because of COVID. It had been, there is quite a tradition of sequencing for quite several outbreaks and so on. There are big cohorts and all that. And I think that we need again to look beyond COVID. This, we should not just see it as a necessary public health tool for this event, but also for quite a few other issues. And this would be an opportunity not to miss, because without this sequencing information, honestly, as Gary says, it's like maybe flying in a plane without radar. And so it is actually, with current technology, it's doable. When I was working on my PhD work, it took so long to sequence tiny plasmids. Today, it's go fast. The biggest issue is maybe the information, the data management, and doing, but all that is doable these days. So there's no time to waste and to lose.
If I could continue with the aeronautics example. And Gary, I've heard you talk about COVID-free zones. So is it possible that we can envision through testing a no-fly zone for COVID?
Right, that's a great question. So if we imagine individuals getting onto an airplane, and we want that airplane to be a COVID-free zone, what that actually means is that if you enter that airplane, you can have confidence that while you're on that airplane, you're not going to be infected with COVID from some passenger who might be asymptomatic, but still is spreading COVID into the airplane environment. And we know that infectious diseases, airborne infectious diseases, do spread within airplanes. Even though the air is filtered and circulates frequently and is cleaned, there are plenty of airborne infections that have caused outbreaks in airlines. So a single unnoticed, undiagnosed COVID positive asymptomatic passenger can infect a number of other passengers, particularly those that are sitting in the seats adjacent to the passenger, in the row in front and in the row behind. So how do we prevent this? Well, we need to screen every single person entering that airplane, and we need to use a test that is highly sensitive and accurate and rapid. By highly sensitive, we want a test that is close to 100% sensitive. That means if you have 100 people entering the airplane, if 10 of them are infected, you want to diagnose those entire group of 10. You don't want to diagnose 7 of the 10 and allow 3 infected persons to enter the airline. The second thing is the test has to be rapid. That is, passengers come to the air terminal, they're screened, they sit down for perhaps 30 minutes, no more. Their test results are then obtained, and those that are tested negative for COVID are then allowed to enter the airplane. So I want to return to this idea of accuracy, sensitivity. Remember that people that are infected with COVID may have different levels of virus. Some will have relatively low levels, some will have very high levels. Insensitive tests could miss those individuals with low levels of virus in their respiratory tract. They might do okay if they have high levels, whereas highly sensitive tests, and the gold standard today is PCR diagnostics. The highest sensitive test done with a PCR device can detect all 10 of those 10 infected individuals and therefore protect the other 100 passengers on the airplane.
Thanks. And I've got a question from Amanda Morris. How often should people get tested after getting vaccinated? Do we have any relevant data about this? And how could getting tested after vaccination impact public health and impact the fight against the pandemic? And in terms of, to the point you were just raising, Dr. Schoolnik, highly sensitive and rapid tests, which tests are best for this type of situation, i.e. the COVID-free fly zone? And do we need any improvements in tests themselves? Do you want to start with that, and then perhaps we'll open it up to others, Dr. Schoolnik? We've got to unmute you. Sorry about that.
Mute.
Okay. Okay, can you hear me?
Yes, we can now.
Okay.
And I love that cut, by the way, Mara.
Okay, that's a great
very
cut.
useful.
Yes, for the situations such as entering an airplane or going to a one-time critical meeting like a press conference or to a sports arena, we need tests that are highly sensitive. Let's step back for a moment and consider what kinds of tests are available today. Well, there are the antigen tests that Mara mentioned. They have the attributes of being relatively rapid, inexpensive. They may be useful in settings where people are being repeatedly testing, such as people tested 3 times a week, because if they miss an individual on one instance, they may pick them up 2 days later. But in these settings where we have individuals coming into a situation where other people may be uninfected and vulnerable, and it's a one-time event like a trip on an airplane, then it's important that we use the other kind of tests, which are PCR tests, because PCR tests have a sensitivity defined as their ability to detect people with both low levels of virus and high levels of virus that exceed 95% and get very close to 100%. If a single individual were to enter that airplane, even though you screened out 10 other infected individuals, that individual could infect another 10 or 20 people on that airplane, those people in the seats adjacent to that individual. And therefore, for those kinds of events, we really require a highly sensitive test. And today that's PCR diagnostics. So you asked the question, how could we make them better? Well, they need to be rapid. They should approach 100% sensitivity, and they need to be cost effective, and they need to be deployable. That is, The right place for such a test is at the entrance station to the airplane, not in some doctor's office, a clinic, or something remote from the testing site.
And Gary, Amanda's following up saying PCR tests aren't as fast. So how do we do rapid tests in airports and stadiums?
Okay. Well, PCR tests are becoming faster and faster. For example, the Visby Medical test from sample to answer is somewhat less than 30 minutes. So that is within the time limit that is required for these screening applications that I've discussed. Unfortunately, most other PCR tests are done on large instruments that reside in central laboratories. And therefore, the sample has to travel to that central laboratory, be tested often in a batch of other samples. And then the result is generated in something like 6 hours to sometimes even as long as 3 days. That's why we need to have the PCR test at the site where the sample is taken, and it has to generate a result within 30 minutes. And there are very few PCR tests that have these features other than the Visby Medical test.
Thank you. And let me turn, Dr. Piot, you've been working in this space for decades. You've seen pandemics and lots of other infectious diseases. Can you offer us a year plus now into this? What are the lessons that we need to learn? What are the things that need to systematically change for us both, to get, as you earlier suggested, this under control for the long term, not just, next couple months, and then obviously prepare for the next pandemic?
Well, it's a long list, but I think the first one is no time to lose. I mean, we often wait too long before going into societal measures, before deploying testing and so on. We wait, for example, in many countries, they waited until mortality goes up. Now, mortality from COVID, when you see death rates going up, that means that these are people who were infected maybe a month ago or later. So you really need to act early. That's the first thing. And in order to do that, you need to have the information. And we're coming back to testing to have the cases and so on. So that's the first thing. And that will remain as important a year from now as today. Because we don't want to go through this, kind of lockdowns and another wave every 6 months or so. So you need to act really early. I think that is the key. And then hopefully a year from now, we'll all be vaccinated. We will see how it goes in terms of action against the various variants. But in order again to know, to assess that, we need to know. We need to sequence more. So we need to set up the systems so that it is part of the of normal, let's say, practice, public health infrastructure, and that needs support. We've been behaving like that. We would set up the fire brigade when the house is on fire. And no, you need a fire brigade all the time. You hope that they will never have to be deployed. So you have to pay people for doing nothing. I mean, to use it that way, that's as some people think it. No, we need that infrastructure, that testing, that but also the leadership to do all this. It's not we can have all the technologies and so on, but without that leadership is important. But I'm also optimistic that as Gary was for for PCR technology, this will improve all the time, and so it will become more and more user-friendly and practical and hopefully cheaper, so that this will be part of the new normal.
Well, and some good analogies today with fire brigades and flying. Gary, were you looking to add something?
No, I'm fine. Thank you.
Let me turn, Mara, to Getting a little bit of feedback there, see if we can fix that. Mara, turning to this COVID relief package that was just passed by the US Congress. $48 billion for local and state health departments to use towards ramping up testing capacity. How do you expect to see those funds used, and how would you like to see those funds used?
That is a big question. So first, let me emphasize that there are a few buckets around testing, the 48 billion that you mentioned, and also the 130 billion for schools, some of which could be used for testing. So I think that the first piece, which has been announced and needs to continue to be supported, is school testing. And yes, it helps kids, and yes, it helps teachers get back to work in a safe way. We know that masks work and mitigate disease, as well as social distancing and hygiene, but tests, for all the reasons we've said so far, but in this case, tests can prove that it's working. I say that first because it's critical to acknowledge that school testing and kids being in person is not just about kids, it's about the economy. And regardless of what study you look at, there are all billions of dollars a week that are missing because parents are home with their kids and kids need to be back in schools. It's a disproportionate challenge for women, a disproportionate challenge to have kids out of work, out of school for people of color, but it needs to happen, and it needs to happen for everybody. So for me, that's number one. Number two is, I hope it's used, actually, maybe an unusual answer, but for the FDA to ensure they can move test authorizations faster through the system. There seem to be a number of tests, anecdotally, it's not published anywhere, that are in process at the FDA. And I don't know if it's that line item or another one, but we've got to get these through. If they're not going to get authorized, move them out. So I would personally have a focus towards active disease testing, as we've talked about today, molecular and antigen, less so on serology tests that there's not been a business case to do. Lastly, it is setting up, and if we have time, I can show a slide about this, but setting up kinds of testing programs we need for the future. Wastewater, COVID sniffing dogs, maybe at airports, scratch and sniff tests, which University of Colorado just came out with a protocol on, breath tests, air monitoring. It's those sort of tests that go into the next stage that can be highly effective when we want people to go back to a congregate setting, but I don't mean somewhere you live, but a sporting event, a concert, otherwise on a rapid basis. So that's where I would use the money. Where it will be used, I don't know, but I'm pleased to see that at least 10 billion has gone into schools immediately.
And round robin, as we close out here, and Mara, I'll go back to you first. What is one thing that you would like to see reporters cover more of when it comes to testing and COVID?
What I would say is that a testing protocol in a school or an office is not daunting. There's a perception that it's difficult to do, that is disruptive. There are so many technologies, from molecular handheld devices to small lateral flow devices. Putting in a testing program gives everybody confidence to go back to school, to go back to work, to go back to play. And it is not hard to do. And the costs of doing it have fallen, I would say, probably 80% since the beginning of the pandemic.
Really good point on confidence. Dr. Piot, for you, what a journalist undercovering on this pandemic right now?
I think how to say, the complexity of the issues, and that's always difficult, that there is no magic bullet. I mean, understandably now vaccination is really very hot, and we won't make it without that, but that it's important to pass on the message. It's not going to be over one fine day, and we'll need to have a combination of measures which will protect us all. And we amply discussed that, you know, that's it's all to really create back a safe society. And that's where testing is an absolute essential role.
Lastly, Dr. Schoolnik, to you, what lessons do we need to take away from this call? If you were to give the sort of top 3 points to journalists, what does the next couple months look like when it comes to their coverage of COVID and testing?
Yes, thank you for giving me the opportunity. I'd like to reinforce some of the points made by the other panelists, and in particular on Peter Piot's huge contribution to infectious disease and public health over his long and productive career. And I just want to emphasize that a public health crisis anywhere in the world is a public health crisis anywhere in the world. We saw this illustrated by what was initially a limited outbreak in Wuhan, China, and how it disseminated globally. Let's keep it in mind that diseases that arise, particularly in, shall we say, the southern nations of the world, the developing countries of the world, can not only threaten the health of the individuals living there, but the health of people living in better resourced environments. We have a responsibility, and I include journalists in this as well as myself as a physician, to be sure that when we think about public health and addressing public health crises, that we make the resources available to everybody in the world, especially those people living in countries that have relatively small budgets to contain public health crises. I've spent my life committed to this. Peter Piot has spent his life committed to this. Please let us make sure that these new vaccines we have are available to everybody in the world, and that good and accurate testing is available to everybody in the world.
Well, that's a great note to end on. And on behalf of this incredible panel and a really important discussion at this critical moment in the pandemic, I want to thank Dr. Schoolnik, Dr. Piot, and Maura Aspinall for joining us. If you have additional questions, we'll put contact information in the chat for how to follow up, and we look forward to continuing this exchange as we go forward into the spring. Thank you.